there specific proposals that some of you who are familiar with the reform as it now stands or would like it to be, that in terms of addressing those kinds of primary care prevention issues, specific things that are or are not or should be or should not be on the table in Washington? Yeah.
I'm not familiar with what's being proposed for the prevention side, but I will echo somewhat what Richard says, that I believe that there should be some mandates in the system that mandate education and testing for people with for HIV. You know, this year, we estimate that there's 56,000 new infections in this country. 1 year, 56,000 new infections. The cost for each case is $15,000. You know, that's $840 million a year would be the potential cost. But then, in addition to that, you have to look at what is the lost productivity of that individual. So I echo, I think that it has to be mandated that certain age-specific education and tests are uniform in this country, whether you're in the private or the public system.
Correct me if I'm wrong here, but of the currently diagnosed, 14% of those are seniors. And we're talking about a population that, if Latinos in general are not getting information, seniors, furthermore, are getting less information. So.
If you saw one of the latest studies that came out on soda, everybody saw that one, that shows that it obviously contributes to obesity. These are simple things that we have not just simply addressed. And from a primary care standpoint, think about how, for all of you, how much time does your physician or the nurse practitioner, whatever, spend with you in the room? How much time do they spend with you? We know the average is under 5 minutes. So if the doctors had their hand on the door before they actually walked in, and they're walking right back out again, where did the education happen? So part of what we have to look at is changing our cost-benefit ratio to that we're spending the funds to have, it doesn't have to be a doctor. It can be a nurse practitioner, it can be a nurse, it could even be a dietitian, whoever it happens to be that has the education to give and share with that patient. But that takes time, and as we all know, that takes money. And so ultimately, we have to remember that's what we're dealing with. And when it comes to testing, it should make a difference what kind of test it is. That's the preventive care that we need to be doing, and that's the front loading again that I talked about. Is ultimately, it takes time for a provider or anyone else to give education. And for simple things that we know, why is it that we have sodas in our high schools and our elementary schools? Why are they there? Those are the things that we have to change, because if we don't, we're just going to continue doing that tertiary care that she's talking about. And those people wind up in our emergency room who had no care at all. And now the bill is a whole lot bigger than it was to start with. So we have to take a reverse approach to what we're doing, because we know what we've been doing doesn't work.
When the soda study came out, and then the national discussion, one of the quotes was that just imposing the tax nationally on soda would bring like $14.1 billion per year. So that could pay for a good chunk of health. The other thing too is that as far as the proof of cost or savings of primary prevention, the Urban Institute, and I'm sorry I can't quote their study, but they have done a lot of work in the past 3 years, going to Europe and also in certain communities in the US to show how the built environment and other activities actually cost, save the community over time.
What would you advocate so that, or what might you articulate that something might get into this bill that over time would make the case for these things in a more compelling way?
One of the things that we need to look at, and I know we didn't get support from the state of California, but I really think we need to look at it. We're talking about soda, we're talking about tobacco, and we're talking about liquor. You know, one way that we can generate revenue, and I know it's a long way away, but looking at the national tax on those items. We do it with gasoline. And it's not like it's never been done before. So that revenues from that will drive and be able to contribute to the healthcare system and early prevention and detection. I think we need to start looking at from a wider perspective and being creative and know that there's going to be a day when it's going to happen.
Okay.
I'm going to be really controversial and talk about something with the potential to raise a lot of money, taxing marijuana, which is an incredibly would be incredibly helpful in raising a tremendous amount of money. If you want to really throw a monkey wrench.
It seems like there's a natural synergy between HIV and AIDS, tobacco, and alcohol. Those of us that are working to prevent those. All of us would wish and desire that in any healthcare reform, prevention activities associated with those three items would be refundable or billable for the services that we're doing. It forces us to work differently so that now the medical personnel maybe are not operating by themselves to keep costs down, and it makes natural sense that that's what they're doing most of the work. We have to include case managers, counselors, at times with just certificates, not necessarily medical licenses or degrees, but it seems like that's a natural synergy that if those three groups came together, I mean, we already have the tools that have been demonstrated to work. The screening, brief interventions with referral to treatment work. And they work in multiple health settings, not just in hospitals, community clinics, but healthcare centers. Wherever you might be getting benefits from the public side, that seems like something we should pull together.
As far as who's doing the work, absolutely, it needs to be the lower, it's a very high-touch system, okay, first of all. And you really need to be able to deploy people who have the knowledge, but who you don't really need the decision-making power from, okay? It's like the diagnoses, that kind of stuff, needs to stay with that health professional who's been trained to do that. But for the education piece, it can roll down to health workers, community health workers, promotoras, okay? Very successful and very cost-effective.
We heard a lot about a great analogy on the safety issue, incentives for prevention, some suggestions of maybe even requirements, mandates on early testing. A tough one, but maybe something still to put on the table. And reproductive health, an emphasis on primary care is more effective. Something I have to say, two words that were spoken about here but not mentioned was public health. I didn't, I heard it underlying, especially your comments, but most of you are providers, right? Most of you are still looking at this one by one, and yet sometimes what you're talking about is 1 to 50.
Right.
Or Jonathan Fielding, 1 to 7 million. I think we need to keep that on the table. I always teach my students about the social determinants of health. What really kills people is not seeing the doctor. It's what your lifestyle and environment and community created. Okay? School-based clinics, school-based education need to spend more on education, on broad-based kinds of educational. Lower level don't have to be specialists teaching people about how to prevent certain things. Soda tax, liquor, alcohol, some combination of those things coming together. And reimbursing physicians and promoters and others all the way up and down that chain for providing effective preventive care. It doesn't all have to be in Cedars-Sinai.